Welcome, everybody. And it's a real delight to welcome with us Alicia and Meredith, who I've wanted to have on this platform for quite a while. I've been following their newsletters avidly for quite a while now. And they cover a wide range of topics. I highly recommend that you subscribe to their newsletter, and we'll give you the link to that later on. They are both seasoned doulas and co-founders of Intentional Birth, which focuses on coaching birth professionals in patient advocacy and informed care. And they also host the Also podcast and share a lot of resources on Instagram, so you can find them there. So today they're going to be talking about perinatal client advocacy and the personalized care with a peaceful heart. So welcome, both of you. Really lovely to see you.
Thank you, John.
Yeah, it's a real pleasure. Thanks for having us.
Great. So tell us a little bit about both of you, first of all. And you're both doulas, right?
We are. And that's how we met. So I will be forever grateful that I chose this profession, or it chose me, depending on how you want to look at it, because there's no way Meredith and I would have crossed paths otherwise. And it was 2015, and Meredith was brand new to the San Jose area. We lived in California at the time. As it turns out, she was only there for a brief stint, a year. And thankfully, we met within that time. But Meredith is a smart doula, and she reached out to other doulas in the area to begin networking. And I was one of the doulas she reached out to, and she took me to lunch. And the reason I went out with her is because she offered to take me to lunch. I didn't have time to do things, but I always have time for food.
Alicia was the busiest doula in the Bay Area, taking a huge load of clients, up to 5, even 9 per month, and just was
Wow.
and so I knew I needed to tap her brain and understand what was going on in the area. And so she said yes. And our friendship slowly developed from there. We realized we shared a lot of values. And I moved away, but we kept growing closer. Well, while I was there, I had my second baby.
Oh.
And there's kind of a famous story of Alicia was supposed to be at that birth, but she'd bought a new fan that day, and a new fan, like in her
Oh, I
room.
see. Okay.
It was
Oh,
hot.
all right.
Her fan made it so she didn't hear my phone call in the night.
Oh,
So
no.
So my
embarrassing.
husband left she couldn't have made it anyway, because my husband left a phone message for her saying, Alicia, I think you might want to come out right about now. And in the background, you can hear me just roaring my baby out because I was literally crowning in that moment. So I caught my baby on my own. My midwife didn't make it either. We moved away shortly after that baby was born, and Alicia and I stayed in touch, and I think just became closer and closer over the years.
We did, which is so unusual when you move away. That's not generally what happens.
Yeah.
But we had so much in common that we wanted to stay connected to each other. And I think Meredith was a little more diligent than I was, so I'm forever grateful that she was.
Well, and
And you
we
ended up in Virginia, right?
we
Where you are
did.
now? Yeah.
Yeah, and just to finish the story, we started Intentional Birth together. Um, in COVID is when we realized, like, we want to start reaching people online in a way that we can't in person, and we developed our childbirth education program first, to use with our own clients mainly, and then Alicia's husband got sick, and she found out within weeks of finding out she was surprise pregnant with her fourth baby. She found out that her husband had cancer,
Oh,
and it
gosh.
was a 9-month journey for both of them. She gave birth 3 weeks before he passed.
Oh, my gosh.
And I was able to drive out and be there with her through that. I caught Jacob myself. And
Oh,
Meredith is downplaying it a bit. Let's just say she was there during some of the most important moments of my life, which were my husband's death, the birth of our baby just 3 weeks before. And she traversed this rocky path with me. And I think we were already solidly best friends, but I
yeah.
think that forever cemented our friendship.
now we're family. And
Yes.
because, after the loss of Shane, Alicia, we just knew we needed to live closer, and so she made her way with her 4 children. One is now away at college, to live near me, and we've been able to continue building life together. And and raising our families side by side.
And building intentional birth into something that we never intended it to be, but we're
Yeah.
so glad we're here.
Yeah.
So
Yeah.
it started as a childbirth education company, and now it's moved into doula training and advocacy training.
Yeah.
Right.
And
Yeah, I was
baby,
going to ask you about doula training actually. So you do that as well. And because in the UK it seems to be a little bit doula training is quite, I was going to say sporadic in terms of like how long it is or how, what kind of detail there doesn't seem to be a standard kind of training. Is there more of that in the US or is it standardized more or less or are you
no,
doing something
it's the
different?
same here. It's an unregulated profession, increasingly regulated as insurance starts to be able to cover doula work. But most doulas receive a 3 day weekend training. That's what we received when we started, and we learn on the job. And
Yeah.
our training is very different. Ours is a year long, and it's much more intensive and robust. And more trainings are expanding in the way that we have because they recognize how deficient it is to throw people into these scenarios with so little training. But I think ours is a little unique in how much we focus on the patient advocacy portion of it.
Mm.
Most doulas think they're going into, squeeze hips and give back massages and emotional encouragement,
Mm.
helping to calm the nervous system. And they don't realize that they're going to have to be doing real diplomacy all the way through a birth in the hospital setting, especially for a family that has maybe an out of the ordinary birth plan that goes against the standard of care in that place.
Yeah. Yeah, so can you tell me a little bit about, I mean, I would imagine the advocacy work is quite different in America to what it is in the UK. I would imagine the pressures are probably a bit different from the hospitals, yeah?
I think I think
Difference.
not too much actually. We've interviewed midwives and nurses in the UK to
Oh,
understand the dynamic there. We were going to bring our advocacy training there last year and had some scheduling issues, but so we have talked quite a bit with them, and we follow quite a bit of quite a few professionals in the UK, and I think the principles are the same. There are similar barriers to evidence-based care in both countries, similar uh, human dynamics, obviously, in both places. And so the advocacy tools that work and strategies that work well in the US are pretty replicable anywhere in the world,
Mhm.
with a few exceptions. Obviously, when it comes to like reporting medical neglect or misbehavior, that's going to be a different system here than there. But
yeah.
mostly it's pretty similar.
It is. As Meredith said, you're dealing with human beings. So the same de escalation tools that work in Kansas will also work in Wales because you're dealing with human beings.
Yeah. And what are the most common kind of issues, advocacy issues you tend to get involved with? What is the most common things that you see?
Well, there's a real lack of informed consent for our clients. So when a woman goes to the hospital, she's being offered procedures, interventions, but very little is often explained about the benefits and the risks and the alternatives of
Hmm.
this procedure. So part of our job is to help her obtain the information she needs to make a fully informed decision. Because when women are fully informed, they feel in control of their birth. They're far more likely to look back on their birth and feel good about the decisions they made when they
Right.
had all the information. And not only the information, but the space and the safety to make a decision that aligns with their own values and their intuition, rather
Mm.
than feeling they were pushed to a certain end.
Right.
Mm.
That's where the trauma comes from, is feeling like they didn't get to actively choose what happened to them. And
Hmm.
I think like at the real essence of it, it is personalized care versus routine care. You have in every birthplace, you have a standard of care that's followed, and there's checklists that need to be um, ticked by the practitioner. And that means that personalized care has to be almost fought for in every situation, because otherwise they're just going to go through the routine plan, and it's not necessarily what's right for this family and their physical health, but also their spiritual cultural framework in which they're birthing.
Mm.
So, and we could get specific, but I think overall that's what we're seeing is we're mostly advocating for personalized care, for slowing down the room and making sure that this family is being offered all of their options and really understands them before they make a choice.
Yeah. So, I mean, if we took something like induction, which is incredibly common here in the UK and in Europe. I don't know what it's like in America, but
Incredibly
Same.
common.
sorry, what?
It's an epidemic.
Epidemic, yeah. And I know, yeah, there's a whole thing we could talk about around Pitocin. But anyway, um, how, because I've looked at this quite a lot. Like, what are the ramifications of induction, but both for the mum and for the baby, really? And obviously, a lot of those decisions have to be made pretty quickly sometimes, don't they? Or there is an apparent need for a quick decision. And I'm wondering, because that kind of situation is the ramifications are so many potentially. How do you manage that kind of situation? Because it's so common here. I have so many mums coming and saying, I've been told I need to be induced next week, and there's quite a lot of pressure for all kinds of reasons, and it's very difficult to unpick those reasons, which might be age and all kinds of things. So how do you unpick all that stuff? Because it's huge, really, isn't it? Even with that one thing, it's huge.
It really is. And this is the perfect example, I think, because it is complex and because there's so much involved. But just to say first that one of the best ways that we've found for women to feel powerful as this induction question comes up is that we've spoken about it. We've prepared them for it. I like to quote Benjamin Franklin, an ounce of prevention is worth a pound of cure. So let's give her some prevention in the sense that we're talking early and often about this. Induction is going to come up. Here's why it might be suggested. Here are the different categories of induction, which we can break down for you, John. Here, there's an induction that's mother-led, where it's an elective induction. There's that kind of induction.
Okay.
There's an induction that's medically indicated, meaning there's a strong medical reason. Performing an induction will keep this mother and baby safe. And then there's one more category.
And it's the biggest category.
It is. And that is, how does
Precautionary. Precautionary induction.
Fortunately, yeah.
So there's nothing right now. Your baby's fine right now. You're fine right now. But we are concerned that maybe down the line, something's going to break down, either because you're way overdue or because your baby's measuring a little small or measuring a little big, because you have gestational diabetes, because you have advanced maternal age, because you're having twins. We could go on and on. These are all, there's nothing wrong right now. Right. Your baby and you are fine. We're recommending this induction as a precautionary measure. And so when we can frame it that way for families, and they can kind of break it down and see, oh, this is not a medical emergency.
Yeah.
This is something that I actually have a little time to consider, that they're prepared. I think the best advocacy is front loaded. And most of our advocacy work is front loaded, where we are preparing our clients beforehand for the kind of conversations they're likely to meet because of the care provider they're with. So with every client, as Alicia said, we have an induction prenatal where we say, because you're with this care provider, you are likely going to have an induction conversation at some point. Here's the possible things they'll bring up. Here's the questions you can ask, not to decline every induction, but to make sure you're getting a personalized recommendation that is aligned with your needs and values.
Exactly. And it's so much easier to do this when there is no drama in the room.
Yeah, of course.
It's difficult to have that conversation when a woman's just been into her provider, the provider's dropped this induction bomb, the mom's calling you close to tears, and you're trying to talk her off the ledge. Like, it's all going to be okay. Far better for her to walk into that visit understanding that this conversation is going to ensue, and she knows what to say. She knows the questions she has to ask. She knows that she can choose that induction or not choose that induction.
Yeah.
And the result is that our induction numbers compared to our early careers when we weren't doing this are extremely low, because most of the clients choosing induction are choosing it because it's a truly personalized recommendation for them, rather than just the routine recommon.
Yeah. And I suppose when you get into things like evidence-based, I mean, it's extraordinary here in the UK how, I mean, I know there's this mantra, isn't there? We do evidence-based medicine and obstetrics, but a lot of it is not. So, for example, coming back to induction, you have one hospital down the road will do it, insist at 40 weeks, another one at 39. And then there's this whole thing that we had a webinar on recently when Henty Goa, and you probably know her work, was
Yes.
talking about the 39-week induction and the kind of myth or potential myth of that,
Yeah.
Mhm.
and the research around that. Again, it's quite difficult to unpick, isn't it? All that,
I
like
think it's,
for the mum, I mean, you
oh,
know.
it's so much. And that's why we do into extensive preparation with her. And
Mm,
in this instance, we would talk about something, the stool of evidence-based medicine, which is basically there are three parts. There is the provider's experience and expertise, there's the research or the evidence, and then the final leg of that stool is mom's values, preferences, desires. So
mm,
all three of those play a part in making a decision. It's not just evidence-based research on its own. We're bringing to bear the physician's experience and recommendation, and we're centering mom's values and her desires.
mm.
And unfortunately, even in this induction conversation, the evidence often doesn't support induction for for most of the conditions,
Right.
actually, where we're talking about big baby, small baby, low amniotic fluid, post
Mm.
states. The evidence doesn't necessarily support induction as improving outcomes in all of those situations, and yet it's the routine recommendation because of the you know phys- physicians and midwives are motivated to give the most conservative care, right? Because they're going to be safer themselves I believe most of them will believe that the baby and mother will also be safer based on their training and their values, but they're also going to be safest themselves, at least here in the United States, from litigation when they act rather than wait.
Mm.
And so taking the most proactive approach, the most conservative approach to
Yeah.
stave off any potential harm is safest for them. And they often make, I think, recommendations from that framework.
Yeah, that's definitely true here as well, I think. Yeah, inevitably. And so if we look at C-sections then, because here that the rate, as you probably know, has gone up. I think it's around 50% now,
Mm.
which is a bit crazy. So
Mhm.
again, how would you use advocacy, say, with a mum who maybe has her own fears around it and really wants to go for an elective C-section? Do you have your own views on that you bring into that equation around advocacy? How do you deal with your own views coming into these kind of situations?
We do have our own views. We have our bias, we have our opinions, and it's so important for us to own that when we're having a discussion with our clients, to lead with that, in fact, to say, look, I have a bias against elective induction.
Right.
And my job here, my task, is to make sure you have all the information and that you are making a decision that you are comfortable with.
Yeah.
But what happens when you lead with that owning of your bias? Then the
Yeah.
mother is, you're creating this environment of safety. She knows where you stand, and she knows that whatever she chooses, you're going to support her.
Yeah,
Yeah.
you're right. It creates this like, oh, non-judgment for each other. I
Mhm.
know I'm not wondering what Meredith's thinking. She's
Mhm.
told me she's told me what she believes, and
Yeah.
she's told me that I deserve to make my own decision.
Yeah.
And these examples, induction, elective C-section, these are actually the easier scenarios for advocacy because it's just about facilitating a really good conversation, helping her make sure she's got the information and feels safe to make a decision.
Okay.
The harder scenarios are when we're in that hospital room, everything's been going swimmingly, and all of a sudden a provider walks in and says, C-section time. Right now, we have to facilitate this three-way conversation, and make sure that informed consent is happening, that everyone understands, sometimes with very limited time, exactly what the concern is, and that our client has the safety and space to make a decision on their own, even when it's go time. Those are more challenging than I think these upfront, front-loaded conversations are.
Mhm.
Yeah. Interesting. So so can you give me an example how you would navigate that then? Like,
Do you mean an emergent type of situation?
yeah, that kind of situation you just described. Yeah.
Sure. Well, I think the principles are the same, whether you have 5 minutes or 5 days to
Mm.
think about it. And it's that you gather the information, and maybe in this instance, you're gathering it as quickly as possible. You're asking questions that are going to get to the heart of the matter, not just what are the benefits, what are the risks, but questions like, Is this a recommendation you make for every woman in my situation? Or is there something you're seeing in my particular situation that's leading you to this recommendation?
Mm.
So, those types of questions that are going to inspire a deeper conversation, even when there's not a lot of time, there's time to ask that question and
Mm.
obtain information. And even when time is of the essence, you can still pause the room. You can
Mm.
still ask everyone to leave for a few moments and give the mother that space. And you can turn off the lights. You can turn on some music. You can encourage her to breathe and to
Mm.
get reconnected with herself, to de-escalate her nervous system, because it's running at an all-time high when something like this has been introduced, right? It's
Yeah.
she's scared, she wants to run away, but how do we bring her back into her body and help her reconnect with her intuition and her knowing that she has? And we do that by pausing the room, getting her safe, and
Mm.
then we ask her what we call the golden questions. There is always time for these three questions. The first is, how is your baby? And the next is, how are you?
Mm.
And the last one is the real gold. It's, what do you want?
Mm.
People tend to make the best decisions when they feel safe. And if
Yeah.
we and what is happening, the reason birth trauma rates are so high is because people are being forced to make decisions in situations where they don't feel safe. So while all
Mm.
of this, like darken the lights and turn on the music and get some time, might sound woo woo to somebody who's just like, checking boxes, what we're doing is creating a memory for her so that 5 months or 5 years or 50 years down the line, when she thinks back on her C-section, she
Mm.
remembers her moment of decision. She remembers somebody telling her, I trust you. What do you want? And she
Mm.
remembers saying, I'm going to do the C-section in a safe place, being
Yeah.
surrounded by trust and love. And she is so much less likely to experience trauma
Mm,
from her C-section if that is what led up to it versus how it normally happens when
mm,
there's not someone there protecting that nervous system and that space, which is that it's just whisked away from her and she can't even remember the moment of saying yes.
Yeah. Sure.
So, a few other examples in this, in a moment like that, our eyes as experienced patient advocates are looking around the room to understand what's happening so we can translate it for our clients. And sometimes that means that we see something other people haven't seen. I had
Yeah.
a client who's the doctor had come in and was standing by her bedside and said, it's time for a C-section now. Your baby's heart rate is decelling. You've been pushing too long. We've got to do the C-section now. And I, as the patient advocate, knew that Pitocin was running in this moment. And I said,
Hmm.
well, why don't we turn the Pitocin off first and see if the baby does better without the Pitocin?
Hmm.
And the doctor at first was resistant to that, but then she said, okay, well, turned it off. And baby's heart rate recovered immediately, and that mother birthed her baby vaginally within a very short period of time.
Mm.
So if as a patient advocate, I hadn't been situated there, probably the family wouldn't have known or to think about that connection between the Pitocin and what was showing up on the monitors. And she would have had a C-section, So we're scanning the room, we're bridging, we're translating for both sides what's happening. One of our biggest tools that we use in these critical conversation moments, we call Be the Bridge, where if there's a breakdown in communication, the family's saying one thing and isn't being heard, or the provider's saying another thing and isn't being heard, we build a bridge in our minds and we start with the client and we say, let me make sure I understand what you're saying. And we paraphrase it so they hear their voice echoed and the provider hears their voice from another person. And then we bridge the other side to the provider. We say, let me make sure I understand what you're saying. And we paraphrase them. And then
Okay.
there's a chance for them to like clarify or we can say, tell me more about that. Tell me more about that. So that now there's communication flowing again. Because when
Mm.
people's nervous systems are escalated, communication will break down. And we see it happening on both sides. Like I see the trauma in the eyes of the provider who lost a baby last week and doesn't want to see it happen again. And I
Sure.
see it in the client, who feels unsafe and coerced in this moment.
mhm.
Yeah. So, I mean, do you end up communicating directly, say, with an obstetrician,
Yes.
like asking, well, why do you feel the need for this? I mean, I guess the languaging side of that is very difficult in the sense that you don't want to challenge them too much, or I don't know. How do you handle that kind of situation. And how do obstetricians generally see you in that situation? Do they see you as a bit of a nuisance, or do they think that yes, great, you're there? I mean, how do you
They should
know?
all love that we're there. They should all love it because in supporting the informed consent process, we're protecting them
Oh
because we
yeah.
will be a witness that our client said yes or said no, right?
Yeah.
It's unfortunately not always
It's
received
much
that
more
way.
complex than
I
that.
would imagine not, no.
And this is how our patient advocacy certification came to be in part, because we recognize that patient advocate is a known quantity. A doula's walking in and introducing herself as her client's patient advocate. The doctor, the midwife, the nurse, they know what that is. They
Yeah.
have patient advocates in their hospital, perhaps. And so rather than doula, doula is kind of a shadowy term that encompasses all manner of doulas. But
Yeah.
patient advocates, that's clear. This person,
Oh,
this patient advocate is going to use her voice on behalf of her client. She
yeah.
is going to be speaking directly to the doctor, midwife, or nurse because
Yeah.
that's the role that she's there to play. Is it always welcomed? No, absolutely not.
And it's very important that the client has authorized it verbally and in writing. So on the client's birth plan in their chart, our clients will write something like my doula and patient advocate is
Mhm.
authorized to speak about any aspect of my care, even outside of my presence.
Mhm.
And so then that puts the medical team at ease. They feel okay sharing information with me and actually sometimes see me as an ally, someone who can help communicate their perspective to my client because they can see I'm more trusted than they
Mhm.
are. And it's not, unfortunately, that's the way it often is with some clients. They don't feel very much trust in their medical care team, and they do feel trust in me. So I become a bridge between two cultures, between two value sets, between two languages to help them come to an understanding so my client can make a really fully informed decision.
Yeah. And in your classes, do you help women negotiate how to communicate with the medical profession? Because it's pretty hard. I mean, as a therapist, I often write letters to doctors and things expressing some concern. But the way I language those has to be very, very careful in the sense that I'm not telling them what to do, because I'm not qualified to do that, and I don't want to upset them. So do you include some of that, like languaging skills for mums, or and
Yes,
also in your doula training, I guess, as well, right?
absolutely. We're there to be diplomats and ambassadors for this client. It doesn't mean we're always going to get it right, but we're seeking to understand everyone in that room. We're seeking to humanize everyone in that room and recognizing that this doctor who's blustering and angry, maybe there's more going on behind the scenes. Meredith just mentioned maybe this provider saw a baby die
Yeah.
earlier this week. Maybe they've had their own experience in birth that's coloring how they're showing up in that moment. So, how can we, as the patient advocate, always show up with humanity and see the person in front of us not as an object to be gotten past or over, but someone that we're going to work with, how to connect with?
Mm.
It's also very important, as you were pointing out, John, for a patient advocate, we're non-clinical. We're in a non-clinical role, right? We didn't go to medical school. We have to be very humble about that. We have to
Mm.
stay curious. The fact is, we know a whole lot about birth, and in some ways, we know more about physiologic birth than many hospital providers do because we see it, and we're there for the duration of a labor, and we see birth in community settings all the time as well. But we have to stay really humble and aware, and we must never make medical assessments or medical recommendations. And so we have to avoid language that sounds like that, and instead lead with questions, share we can share our perspective. I think many doulas are too shy about that. They don't own their own expertise, but to say, Dr. John, I actually have a different experience. I have seen this other thing at other hospitals. What's your perspective on that? Right? Rather than saying you should be doing things this way, right? Because that's just not going to go over well. It's not
Mm.
diplomatic. It doesn't build humanity.
No, exactly, exactly. And I mean, do you ever, because on our platform, we are particularly interested in the baby's experience, and that's often overlooked in the whole birth arena. So I was interested in your question there, Alicia, about What was it? What does your baby, what was the question about? What does your baby feel? No, what does he say? What is,
The golden questions.
yes,
How
yes.
is your baby?
How is your baby? Yes.
And it
What,
isn't important.
what does that, how does that translate into practice? Because I mean, if I asked maybe some pregnant mums, perhaps they wouldn't know how to answer that, would they?
It's true. It's true. And that's why we're encouraging our clients throughout their pregnancies to connect with their babies and their own bodies
Yeah.
and to get embodied through movement, dance, whatever it may be, meditation,
Yeah.
affirmations. And the more that they do that, the more they build that muscle of connecting with their heart and with their baby. And
Mm.
so that's our hope that they've been doing that throughout their pregnancy. So
Okay,
when
so
we
they would have
ask
done.
them that question, they
Yeah.
can answer and say, my baby's okay, or, oh, I think my baby needs something different.
Yeah.
Women know, they do know if they haven't had their intuition clouded by too much information and too looking outside themselves for expertise.
Yeah.
I think, when we teach advocacy, we have, 25 concrete tools and all these words and phrases and all of these systems and strategies to get your client personalized care. But the most important advocacy we do is inside the client herself, so
Mm.
that when we're with her prenatally, we are constantly reflecting back to her our trust in her,
Mm,
our belief in her, and showing her she can trust herself and believe herself,
Mm.
because so that she learns to advocate inside of herself for what she needs, what she wants, and recognizes that she knows how her baby's doing,
mm,
and not that she can't take into consideration all of the amazing medical tools that can give us insight into a medical condition, but that, going back to your question about like the induction or receiving an ultrasound in late pregnancy is often what leads to that induction recommendation. Well, that choice to get an ultrasound, that's fine. For some women, that's going to bring them reassurance, see that their baby's okay. But we also inform them about, the possible findings that might come up from an ultrasound. And so
Yeah.
before she goes into that ultrasound, we guide her through a process of getting still and asking herself the golden questions of how am I and how is my baby? So she has that data to compare with when she
mm,
gets the data from the ultrasound or the NST, and she's puts it in the place that it deserves, right? That is important information and it's
mm,
valid information. So
Yeah.
our clients are getting practice in this, like just being still and listening to themselves throughout their pregnancy,
mm.
so that in that moment they can, and it doesn't, when we say how is your baby, they can take into consideration whatever the CTG monitor has told their
Yeah.
doctor. But then
Yeah.
we're also asking them, like, just if it was just you in your body with your baby right now, what is your body telling you? They
Yeah.
know.
Sure. Sure. I mean, I suppose, do you ever have situations where you might feel you want to advocate for the baby more than the mum, or you might see something. Do you know what I'm saying? Where can there be a bit of a conflict where you say, well, actually, this would be better for the baby this way, but it's not so great for the mum? Do you get those kind of dynamics going on sometimes?
Sure. And I think in those moments, we seek to remember what our task is. And our task is to not make decisions for the mother based on our own values or preferences, but instead help create this space where, as Meredith said, we can allow her to, she doesn't need to be allowed, where she feels safe to tap into her intuition. We're modeling that trust in her so she can turn around and enact that trust, where she sees that we trust her and her confidence is boosted that she can trust herself. But coming back to the task, our task in that moment is not to decide what is best for her or for the baby. It's just not. That's her task. Even though we
Yeah.
may think something else should happen in that moment, but does she have all the information? Does she feel safe to make that decision? And then does she feel supported as she walks through that decision?
In the
Yeah.
end, our task in that regard is the exact same as all the medical professionals. And this is the reason the medical system has become so traumatizing for so many, is that people are forgetting their task. They think their task is to save her or her baby from a bad decision. Their task is actually to make sure that she has all the information and that she's safe to make a decision. And most of the time, if those things are in place, she'll make the best decision for herself and her baby. And sometimes she won't, and that's not our task. Like in the end, what I'm advocating for is not her specific choices. If I think that that's what I'm advocating for, I'm going to fail in my advocacy because I'm going to disagree sometimes.
Mm.
But what I'm actually advocating for is her right to choose. It's her legal right and it's her human right to
Mm.
choose. As long as that baby is inside of her, you know, in the United States, ACOG is the governing body for obstetricians and gynecologists, and they've said that pregnancy is not an exception to the rule, that a decisionally capable person can choose to decline any intervention, including an intervention that's intended to preserve life. So
Wow.
for herself or her baby, she has that right. My job is, of course, to give her the most human care and make sure she feels like she has all the information. But my job is to make sure she's able to make that decision without coercion.
Yeah.
So it is hard. It's challenging to see a client sometimes do something different than what we would do ourselves. But when we remember that that's her task, not ours, it allows us to operate with integrity and because there is no prognostic certainty, right? So I might think the baby's struggling based on what I'm seeing on the CTG, you know, in my head. I'm never going to say that out loud because I'm not a clinician,
Yeah.
but I might think that, and I can ask her some pointed questions to make sure she understands that there is a genuine medical concern here. But in the end, we might all be wrong and she's right.
Mhm.
Yeah.
And only time will, show that. So,
I mean, what you're describing here is very beautiful, and it's sort of like obviously it takes a lot of more time than perhaps I've seen here with a lot of doulas in the UK. I mean, well, certainly that, and what you've talked about your training, it encompasses all these things you're talking about. So it sounds like you're spending much more time with mums, perhaps, over
Oh,
over the course of the pregnancy, right?
absolutely. And thorough education. This is why we developed our childbirth
Yeah.
education because we were finding that we couldn't fit it all into the prenatal time we had with our clients.
Yeah.
There was so much more, and we wanted them to take responsibility for their care. And so we created this online childbirth education that's almost 20 hours long.
Yeah.
And it's the parents' responsibility. We're right from the get go, we're letting them know this is your responsibility to get educated. We're simply going to follow up, ask questions, fill in gaps, and you go get this education. Here it is. And you're going to take it from there. But we feel a sense of obligation as doulas to educate our clients, to share everything we know.
Yeah.
That way they're walking in with their eyes wide open.
that's
Yeah.
the ideal, is the front loading. And we've both been doulas where we walked into a hospital room and met a family for the first time because we were either backing up another doula or we were hired last minute. And
Yeah.
it is possible to still do excellent advocacy in that situation, but you have to sit down with the family right when you get there and learn who they are, what their values are,
Yeah.
how do you want to feel about your birth when you remember it?
Mm.
How do you
Right.
want to feel about each other when you remember it? Okay, now I know exactly what they need from me, how I should be navigating this room with them. And I'm going to constantly be turning the spotlight back to them. If I feel like someone else is kind of holding the power in the room, my job is to politely take that and put the power back in my client's hands.
Mm.
And you can do that with no formal relationship with them. And just letting them know their rights. Most families don't know that they actually have the right to make their own medical decisions. Many feel like the doctor is the police or something, And so you can do that education in 2 minutes. Explain to
Right.
them, one of my roles here as your doula is to be your patient advocate. And I want to help you understand exactly what your rights are so that I can advocate for you well. You can do that in 2 minutes, right? And then they're going to have such a different experience than if you weren't there with them.
Yeah, and I guess you're bringing in, there must be a lot of cultural things. Like I do a lot of work in Eastern Europe, and there's this still a kind of view of doctors and obstetricians. They're kind of like, you don't question anything, you just don't. It's like that. And I guess culturally, people from different, all the whole variety of cultures that we have and you have there, they will have different attitudes towards authority, for example, won't they?
Right.
So I guess sometimes you're helping them maybe to bring up their, I don't know, empowerment, right? Their self-confidence to be able to challenge these things or at least even talk about them, right?
Absolutely. We have to be culturally aware as we're working with our clients because that is going to impact. And we're talking about family culture, we're talking about religious culture, we're talking about political culture, ethnic culture, all of it comes to bear in the birth. And this is the opportunity that we have for really honest, open conversations. For instance, Meredith and I worked with a lot of Indian families in the
Yeah.
Bay Area, and they come from a culture that you're describing, John, where they're more likely to deem a doctor as the one in charge of
Yeah.
this birth. And I won't question them because they hold the authority. So what we're doing is we're acknowledging that, we're asking questions to understand where they're at, and then we're inviting them into a new way of thinking about this, a new way of being. And we have seen absolute magic from parents who accept this invitation and say, I know this is how I was raised. I know this is what I used to believe about medical doctors, but I'm shifting that. And I'm recognizing that I can step away from that culture in
Yeah.
favor of a new culture for my family, one where we center our family, our autonomy, our values.
And we collaborate with our physician as an advisor and a, and a collaborator rather than as someone who's dictating to us what to do. And Alicia had one of her Indian couples that she worked with in a prenatal, as she was teaching them this stuff, the dad turned to Alicia and said, "We are being transformed." And they
Wonderful.
were. I mean, to tell their birth story would take more time than we have today, but they were completely transformed by birth.
Really?
Yeah.
Wow.
And
Cool.
that's
Uh,
the whole point in our minds and hearts that parents are transformed by birth. That transformation is going to look a little bit different, but I think for almost universally, the clients that we work with, part of that transformation is taking back their power and holding on to that power and
Yeah.
recognizing forever after that they make the decisions for this family. And that's so important because as they're stepping into parenthood, perhaps for the first time, they need to recognize that they are the ones who are going to be making decisions for the life of this person that they are
Yeah.
now responsible for. And we want them doing that in a way that's in tune with their intuition. And so birth is just the beginning of that.
Mhm.
And what, I mean, as a result of all this, so you mentioned about seeing perhaps less inductions and stuff, but do you follow up with families afterwards? Have you noticed any patterns in terms of like, I don't know, better attachment or less postnatal depression or these kind of things? I mean, anecdotally, have you
Oh,
know,
sure.
Absolutely.
For sure. I mean, I'm trying to think like of examples, but there's so many families that I've worked with in this paradigm, and I have a basis for comparison because I didn't work like this in the beginning. I worked like I was trained, and I was trained in my doula training not to speak to hospital staff,
Oh wow.
and I just was seeing so many traumatic things and feeling like, shouldn't I be saying something? Shouldn't I be doing something? And I learned really quickly that's not the way I wanted to operate, and that there was no reason to operate that way. And so I have seen a huge change in the in I don't know. I so many those families I think all had good bonds with their babies and things were good. But when you would ask them how your birth was, they'd be like, it was okay, you know. And now it's I see more transformation of the kind Alicia is talking about, where they're
Mm,
really truly they know themselves and they're ready to step into their authority as a parent,
mm,
and they're also humble in the face of their calling of parenthood too, because they recognize the deep responsibility that they hold.
mm,
But I don't know, just the change is dramatic in terms of how much trauma is impacting their early years as parents, or their early days even as parents, versus a sense of even when the outcome wasn't exactly what they wanted, they still felt like they were in control and in charge, and they feel proud of themselves and they feel self-respect
mm,
and they feel safe in the world.
mm.
So I don't know. Yeah, anecdotally, yes.
I think it's so important because a woman who finds her strength in birth will be able to then find her strength in motherhood too. It's this idea of I was able to do this thing that I wasn't sure I could do. I
Yeah.
did it. And now I can do this thing that I'm not sure I can do, but I think I can because I gave birth. And
Yeah.
we want it to be a place for her to return to again and again when her confidence is wavering. I am strong. I am powerful. Look what I did. And it
Yeah.
opens up a whole new world to her. And what I see parents happening down the line as I've stayed in touch, it's interesting how this has shaped their future decisions, how they've chosen to school their children, how they've
Mm.
chosen to feed their children and their families,
Mhm.
the decisions they make around, let's say, vaccination or medical care for their families. Suddenly their eyes are
Footwear.
opened.
I'm
Footwear,
I'm
yes!
just I'm thinking of,
Movement, yes, all of
yeah,
you.
What did you say? Footwear? Did you? What?
footwear. I'm just thinking about all my clients who like have just been more intentional and mindful about every aspect of their lives
Yes,
because they learned through birth to be that way.
yes.
Ah, cool. Yeah, that's wonderful. I suppose what in an ideal world, when would you like to start working with uh I'm going to say a mum, but I also would like to bring the dad in here, but I've got
I would say
family. So.
menarch when they have their first period. I would love to start talking to them. Um,
As early as
yeah.
possible.
So
We want,
before they get pregnant, right?
oh, that would be ideal.
That would
Oh
be
my
amazing,
goodness.
especially in terms of preparing their body and nervous system for the experience.
Absolutely.
But the earlier the better. Yeah, I just as early as we can in the
Mhm.
pregnancy.
Yeah. And you must Alyssa, you were talking about your experience very openly there with your own birth, and that must have really impacted your work and must have enabled you to bring a lot of compassion and understanding for people suffering into this work, right?
I think so. I think I've been changed. Birth and death are going to transform you, whether you like it or not. There's no way to get away from it. And maybe this birth and the death of my husband Shane, those have been the most transformative events of my life.
Yeah.
And even though I had given birth 3 times prior to that, this was my most intentional birth, where I was really thinking through what do I want? What's best for me and my baby?
Yeah.
And and then choosing that. And as a result, I had a very different experience. It was my most difficult birth, but I think it was because I allowed myself to be in it fully and completely. And I felt probably the safest I've ever felt with Meredith. And because I trust her and I know she trusts birth, and my husband, unfortunately, wasn't able to be there. But Meredith made a wonderful birth partner. And that sense of safety, I think, has influenced me forever, recognizing that that is how I want to show up for families. So
Yeah.
a mother feels completely free in her body and her mind to do and say whatever it is she desires to do and say. And I had never felt quite that free in birth before.
It
Yeah.
was interesting. It was a very educational experience for me as well. In that, at least they had just moved to Colorado for Shane's treatment, and Alicia didn't have time to make connections, and so she chose to have this birth unassisted at home with me. We're both experienced doulas. We knew what to watch out for, and we also had midwives on the phone that we could call
Yeah.
if we needed, and we had a hospital nearby. So we were very prepared for contingencies if needed, but it was an uncomplicated, beautiful birth with just the two of us. And to see what happened when no one, not even a gentle midwife, like was giving instructions or saying anything, it was
Yeah.
amazing to see when this baby was born into my hands. And then Alicia stayed in the birth world complete because I didn't pull her out of it. I just held her baby until she was ready. And she stayed completely in labor land until the placenta was out. And I'd never seen that before because in the hospital setting, especially, but also in home birth settings, there's a lot of like talking and moving things and doing things. And it was just this perfect stillness while Alicia waited to return to her body and to greet her baby. And it was a holy moment. a moment in which Alicia received her baby's name and was just like it was a sacred other sphere. And
Wow.
then when her placenta was born, her eyes popped open and a smile jumped onto her face and she reached out and saw her baby, and I saw joy on her face for the first time in many months
Mm,
because of everything that she, until that moment she'd only been thinking about Shane, and now she
mm,
could think about this baby. But the reason I'm telling this story is that when, as a patient advocate, if you have no experience beyond the hospital room, you don't know what birth can be, and you don't know what it's possible to advocate for. And if you
yeah,
don't really understand the possibilities, you're handicapped in your advocacy because
yeah,
you can't say, "Hey, actually, after your baby's born, you can wait to hold your baby. You can
yeah,
stay, we can have the room be quiet and peaceful while you return to your body." And we can create a sense of sanctity and safety in the birth room, even in the hospital. If you've never seen it outside of the hospital, you don't know how to incorporate it there. So, part of our deep encouragement to anyone who's attending birth is to get experience in many settings, is to see birth completely undisturbed if possible, so
yeah,
that they then know what's possible in every setting.
Mhm.
yeah. Gosh, that's very powerful. I mean, it's sad, isn't it, that people won't, most people won't have seen that kind of thing or experienced that kind of thing. It's very sad, isn't it, in our
We
culture?
always share the story of our good friend Jess Shinneman, who was a labor and delivery nurse for 10 years. She'd
Mm,
worked in a handful of hospitals and seen 1,000+ births in her time.
mm,
And it wasn't until Jess and I attended a birth together, and that my clients had chosen to have an undisturbed physiologic birth
mm.
in the hospital. Jess was the nurse supporting us that day. And Jess, for the first time, saw what it looks like when a baby emerges on its own. That baby emerged into dad's hands. And Jess had never seen that. And then dad passed that baby up to mom. And mom and dad and baby just sat and bonded together in peace and quiet. The placenta was born spontaneously. None of this had Jess ever experienced in her years as a hospital labor and delivery nurse. And so
Wow.
I think so many providers have just simply never had that opportunity. And so we as advocates, as Meredith said, it does behoove us to see the full gamut of birth so we can take it to our clients and say, this is what's possible. What do you want?
Yeah.
Yeah.
And they might still choose the elective C-section,
Sure.
but if they haven't been able to look through every portal, and decide which one they want, then it's not a it's not a fully informed decision that they're making.
No, sure. So coming back to your training, because we got to stop in a minute. It sounds like you've put so much thought into this whole thing and what you, I suppose, like in terms of like what kind of changes you'd like to see in terms of the doula training and advocacy training. And you mentioned about how you were going to do it in the UK. As far as I understand, you have an online training right now, but you
Yes.
also wanted to do it in the UK. Is that right?
We're mostly in person. We do offer it online occasionally for people who can't make it to a in-person training.
And we have two forms of training. One is our doula training, where
Yeah.
we're teaching doulas business. This all happens online. So doulas around the world have joined us. We're
Yeah.
teaching them business, physiology, advocacy, and integration. And then what Meredith is referring to is our in-person perinatal patient advocacy training.
And that's a 2-day training.
Okay.
So where we teach all of the advocacy principles and foundations on day one. And this is, the people who come to this are generally very experienced birth professionals already, or
Yeah.
at least have some experience. And then on day two, we role play all day long. So we've got the white coats, we've got the scrubs. We bring in real L&D nurses,
Wow.
I don't know what you call L&D in the UK, labor board nurses, and we practice real scenarios. They're all true stories, real scenarios that we've experienced and that the doulas will have experienced if they have if they have been doing this for any amount of time. And we practice all of the words and phrases and advocacy and just the way of being.
Yeah. Yeah. And that people can find out the information through intentionalbirth.com, is that right? Intentionalbirth.com, is that?
.co.
Intentionalbirth.co.
.co, sorry. Intentional.co. Okay, cool. Oh, it's so lovely to have you on. I really appreciate it. Thank you.
Oh, God, thank you for having us here.
And what just to finish, what can I just ask you, what would you like to see changing in the birth world right now?
So much. I think one thing I'll just say for my part,
Yeah.
I would like a reduction, a major reduction in trauma, both for doulas and for families. It's estimated that 25 to 35% of American women are coming out of their birth feeling traumatized by the experience. And that breaks my heart because birth is a mountaintop, a pivotal experience, seminal in a woman's life, and it shapes her forever. So is she coming out of it in tatters and just in pieces? Or is
Mhm.
she coming out of it feeling powerful and capable and ready for what's ahead? And I also want doulas to have trauma reduced because so many doulas get into this profession with such excitement and joy. And then in 2 or 3 years, they've burned out because of what they've seen and they don't know how to advocate. So our goal is trauma reduction for moms, for dads, for doulas.
Mm. And I think that's probably also true with midwives,
Yeah.
isn't it?
Oh, yes.
I mean, I know a lot of midwives who have been extremely traumatized. I mean, they would often say they've got PTSD as a result of having to do things that they knew were not helpful or even harmful. So yeah, I
Mm.
think we could apply that definitely to midwives and maybe dads.
Mm-hmm,
For sure.
absolutely.
You know,
Absolutely. Everyone on the birth team.
many dads are quite traumatized by watching
Mm.
their
Mm.
wives go through these kind of things. So yeah.
Yeah.
What do you want to see?
Anything you want to add, Meredith?
Amen on all of that. I think helping the midwives and the doctors feel safer would actually make everyone safer.
Mm.
And the culture that we have right now is one that is very dangerous for them to practice in.
Mm.
They have to be very self-protective, and or they're going to lose their license or they're going to get sued. And it makes it difficult for them to give really personalized care and to listen with love to the patient in front of them
Yeah.
because they have to be so self-protective. And
Mm.
so there are a lot of, policy things that need to change as well, as the things Alicia talked about, the personal human care that needs to be received by families.
Yeah, absolutely. And one thing that we're quite keen on this platform is also for us to look at our own histories, and how that is impacting the way that we work and the way we view birth. And
Yes.
but that's very helpful for people to kind of understand why they do things that they do. So
Yeah.
Yes, absolutely.
cool. Well, thank you so much. So intentionalbirth.co, have a look, please, and do sign up to Meredith and Alicia's newsletter and get all the information. And thank you so much, both of you.
Thanks,
Thank you,
John.
John. So nice to be here.